Good evening everybody. My name is Dr. Poonam Negi and today we are going to discuss about brain death. So let's begin with the case. It's a 52-year-old male who has undergone cardiac arrest while at work. He was revived after 40 minutes of CPR and on arrival at the hospital he has undergone targeted temperature management at which he was maintained at 36 degrees centigrade for 24 hours. He was then rewarmed to a temperature of 37 degrees over the ensuing 4 hours. The next day, when his neurological examination was done, he was found to be comatose with no brainstem reflexes and no movement in his arms or legs other than the bilateral triple flexion signs in response to noxious stimulation. He is no longer breathing at a higher rate that which was set on the ventilator. Vasopressor medications were required to maintain his hemodynamics with an SBP of around 100 mm of Hg, and there was a global anoxic injury which was observed on the CT. So, what would we establish the diagnosis here? Based on the circumstantial evidence, he is a post-cardiac arrest patient and who has undergone targeted temperature management, and post-rewarming after a certain observation period, he was found to have a comatose state with no brainstem reflexes. So obviously we would arrive to a diagnosis of brain death. So before we merge into brain death, let us know a little about the history of the brain death. The notion brain death was never there before 1950, or if I may precisely say, up till the advent of the positive pressure ventilation or mechanical ventilation. In 1950, the concept of the death revolved around the cessation of the cardiorespiratory function. That is, the patient would go into apnea, hypoxia and a cardiorespiratory arrest. Prior to the development of the positive pressure ventilation or the mechanical ventilators which we call, then the question of neurological death or the brain death came into question. So, for the first time in 1959, the concept of brain death or death by neurological criteria was first theorized, and it was called as Lee coma de passe, which is in a French term by Molleret and Goulon, because they had observed neutral electrical activity on the EEG. So, in 1968, a group of Harvard faculty proposed the Harvard brain death criteria, which consisted of clinical and EEG criteria. Finally, in 1995, American Academy of Neurology had come up with the guidelines on determination of BD, that is brain death, or DNC, which is death by neurological criteria. So, what is death? Death as per THOA, that is Transplantation of Human Organs Act 1994, is a deceased person means a person in whom permanent disappearance of all evidence of life occurs. It can be by reason of the brainstem death or in cardiopulmonary sense at any time after live birth has taken place. In a sense, there is all functions of the brainstem which has permanently and irreversibly ceased. So, how do we define brain death? It is a complete, please note it is a complete and irreversible cessation of the brain function, including the capacity of the brainstem to regulate the respiratory and vegetative activities. The respiratory has to be underlined because in a brain dead patient, it is the respiratory arrest which happens, not the cardiac arrest. So, what is the brain death? In short, it's a clinical diagnosis which came into surface only after the invention of the mechanical ventilation, and the brain death progresses from rostral part of the brain to the caudal part of the brain, wherein the brainstem is the last part of the brain to die. Hence, in few countries it is also being called as a brainstem death, and in the brainstem it is the medulla which is the last part of the brain to die. So, what is the pathophysiology of a brainstem death? So, for a brainstem death to occur, there should be a catastrophic event in the brain which had occurred. The catastrophic event can be in the form of a traumatic brain injury or a cerebrovascular accident, which can be an ischemic CVA or a hemorrhagic CVA like an intracranial bleed or a subarachnoid hemorrhage. It can be a hypoxic insult like how we saw in our case, the post-cardiac arrest case, or a metabolic insult to the neuronal tissue like hepatic encephalopathy it can be, or because of various other endocrinal causes, or a raised ICP secondary to a space occupying lesion, cerebral edema, reduced cerebral perfusion pressure, or finally herniation of the brains. So, what all catastrophic brain injuries? See, we can see in the picture, the first picture here depicts this CT of the brain, which is showing a massive intracranial bleed with a midline shift. The second picture shows a massive MCA territory infarct with a midline shift. This we can see a space occupying lesion which bleed inside with a midline shift. This is a CT of a patient who has undergone cardiac arrest. So here we can see that there are loss of sulci and gyri effacement. Then there is loss of differentiation between the sulci and gyri. In addition to it, there is a diffuse cerebral edema. The basal cisterns which are supposed to be present here have been obliterated. So before we diagnose a brain death or DNC, that is death by neurological criteria, we need to rule out certain confounders. The confounders can be in a form of medications like sedatives, the opioids or benzodiazepine overdosage, or in the form of toxins like organophosphorus compound toxins it can be, or it can be a simple snake poisoning mimicking brain death, or neuromuscular blocking agents like high vecuronium dosage has been given to the patient. This electrolytemias like hypernatremia, the sodium levels going above 160, or dyselectrolytemia with the sodium levels going below 110, severe acidosis or alkalosis, endocrine imbalances like hypoglycemia, hypothermia, hemodynamic instability with the patient requiring high dose of vasopressors, dual, triple vasopressors. In case of facial or ocular trauma, wherein the clinical examination can be a confounding factor because of the trauma. Refractory hypoxia, hypoxic encephalopathy can also be a confounding factor, or a cervical spine instability again, wherein your clinical examination may get precluded. So we rule out all these confounding factors which are also called as brain death mimics. Only after you rule out all these confounding factors and you are very sure that they have been removed, then we go to the next. So what is the time lapse before diagnosing a brain death? So in case our patient had a cardiac arrest. So in case of a patient who had a cardiac arrest, the standard guidelines say that there should be a time gap of 24 hours after the attainment of ROSC, or even up till 72 hours to diagnose a brain death. In case of confounding factors like opioids or medications or toxins, or in a patient who has a renal or hepatic failure and you suspect some toxin or opioid overdosages, you are supposed to wait for at least 5 half-lives of that particular drug to get excreted from the circulation to term a patient as brain death. For pediatrics, the rules are little different. For in adults, we usually advocate for single brain apnea confirmation or brain death confirmation through the apnea test. But in pediatrics, there should be 2 separate clinical examinations, especially in neonates. 2 separate clinical examinations should be done 24 hours apart, and in infants and children, it should be 12 hours apart.